Well, hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and welcome to the Australian Anaesthesia podcast. For those of you who haven't caught up, I am back from my break in terms of podcasting, and I couldn't pick a better series to begin with than the podcast I recorded whilst at the ASA's National Scientific Congress in Darwin. It was a fantastic meeting. Huge shout out to Dr. Bridget Brown, the convener, and Dr. Indy Lin, scientific convener. It truly was a really good meeting. So in this episode, I am sharing with you my conversation that I had with Professor Ki-Jinn Chin, who is based in Toronto and is also the director of the regional anaesthesia program there. So naturally, I pick his brains for tips and tricks about regional anaesthesia, and I was really fascinated about the block rooms that they have there in his hospital in Toronto. He is also a content creator with hundreds of videos on regional anaesthesia available on YouTube. So naturally, we talk content production, as I know more doctors and health professionals are getting into making videos and podcasts. So we dive into that as well. All right, let's get into it. Well, thank you. Thank you for joining me this afternoon at the Congress, at the podcast booth. You're from Toronto.
I am. I currently live in Toronto.
Okay.
It's not where I was born.
Okay.
Toronto is home for now.
How long have you been in Toronto for?
Toronto since 2007.
Okay, so what are we, about 15,
coming
20?
up to 15,
About
coming
15
up
years.
to 15, 16 years.
Okay,
Yeah.
good. And what's Toronto like? Paint me a picture.
Toronto is probably the biggest city in Canada.
Mm-hmm.
An interesting blend of a very modern metropolis planted on top of an old city, which drives some people crazy.
Yeah, right.
Yeah,
So is there like an old town and then sort of spread
so
around
there's some
it?
areas where, buildings are 2 stories high. We have
Yeah.
streetcar tracks running through it. And then we've got like condo buildings that are 50 stories tall.
Right, okay.
But it's become this amazing place to live, huge melting pot of cultures.
Oh, great.
All the food you could wish for from every corner of the world. So.
That's even Asian food?
Oh, yes.
Because it's a long way from Asia.
Not quite on the level of Australia or Darwin, but
Yeah.
pretty good.
Yeah, cool. Now, you grew up in Singapore.
I did. I grew up in Singapore.
Have you been to Darwin before?
No, it's first time.
Oh, okay.
Yeah.
How do you find it? What do you think of it?
It's been fantastic. It's been nice to be sort of warm and sweating again.
You're used to the climate.
Yeah. And I think just to also now, I've never really seen much of the indigenous culture. I know I'm just scratching the surface.
Yeah.
And I feel like it's a bit that I'd like to know more about. But that part of it's been very interesting.
Oh, good. Yeah, I constantly feel like that's 100% relate. Now, you've taken a bit of a path with your anaesthetic career. So where did you start?
Well, so I went to medical school from Singapore to Newcastle.
Newcastle upon Tyne.
In the UK. Not Newcastle,
not
Australia.
out,
Newcastle upon Tyne. It's interesting. I did anesthesia and don't remember very much of it.
That's what most of our patients say.
Yeah, that's true. And maybe that's a hallmark of medical students in the UK. Yeah. And then I did the usual house jobs in medicine and surgery and decided I didn't want to be a surgeon, but I thought medicine's quite interesting. And I went home to Singapore because we'd have to do national service and I put that off. So I had to go back.
Okay.
But I did 9 months of internal medicine.
Right.
Decided that clinics weren't the thing for me.
Yes.
But I
can
had
relate.
2 months of medical ICU and that really interested me.
Yeah.
So I thought, how can I get the kick of intensive care but still have a bit of a life? And anesthetics was what seemed to tick all the boxes.
Lovely.
So I went from there into anesthesia and I stayed in Singapore to do that.
Yeah. And because you picked up a fancy along the way.
That's right. Yeah. So those are the days when they recognize, I don't know, they still do, but they recognize the training and just had to sit the exams. And because I always thought one day, Australia seems like a pretty cool place to work. I just want to make sure I have that option.
You've probably got a global ticket, I think, because it now. So what took you to Canada?
So it's very normal for people to do a fellowship and often overseas. I actually have a bit of a history of Canada because my parents are both doctors. My mother's Singaporean. My father was born in Malaysia. They went to medical school in the 60s. And for some weird reason, both Singapore and Malaysia had an arrangement with the University of Saskatchewan in Saskatoon to take students from Singapore and Malaysia. And my parents, one came from Penang, one came from Singapore, and they met there.
Oh, wow.
And came back and got married. And So I've always had this Canadian connection in the background. So I was like, oh.
Are they still there or are they?
No, so they went back to, and they're in Singapore.
Okay.
But just like, maybe I should go and see what Canada's all about.
Yeah,
and
cool.
ended up, I didn't actually end up in Toronto first. I went to London, Ontario.
Okay.
Which is a small city about 2 hours west of Toronto. And I did neuro anesthesia.
Okay.
But by the time I was doing that, I kind of thought, actually, I really love regional anesthesia.
Okay.
I applied to Toronto. I was lucky enough to get a fellowship with Dr. Vincent Chan, who really is the legend of ultrasound guided regional anesthesia, and never looked back since. And it was an unbelievable opportunity.
Wow. So in terms of your practice now, how much do you think is regional versus non-regional?
It's very much a focus. I mean, I work in a tertiary hospital where we focus mainly on, I guess, major orthopedics and neurosurgery, spine surgery, other sort of big focal areas. So that's where I would spend most of my time. Between directing the regional anesthesia fellowship and being the clinical director, probably about 50-60% of my time is doing blocks.
Wow, that's a great number. Yeah. You must be fantastic at blocks. Because it's great practice, right? I mean, you get better with practice, And
I think the way Vincent set it up a long time ago with a block room, I think we had a block room ever since I had been there.
Yeah, because we don't have block rooms typically in Australia. I think there's a few centres now starting to introduce it. Tell me how that works.
So the way it is that you centralize the performance of all the blocks for the operating room complex in one location. So anybody who's scheduled for a block will come to this block room, have their block, and then they're passed off to the operating theatre.
Wow.
There are pros and cons. So definitely a central. The blocks tend to get done very well, very efficiently. I would say the biggest drawback, I think, sometimes is that it can de-skill people who aren't part of that block room staff. Yeah. And I sometimes feel a bit guilty about my other colleagues might not get the opportunity to even do spinal anesthetics.
Yeah, right.
Except when they're on call, and it can then be very daunting.
So the spinals are done in the block room as well?
Yeah, we try and do almost everything.
Wow, impressive.
I mean, we still have a limited capacity. Our block room has 4 bays at the moment, so occasionally blocks have to be done in the operating room, but by and large, the vast majority are done in the block room.
That's impressive. So you've got a block room with 4 bays. How many theatres in your complex is this servicing?
There are 12.
Yeah, wow.
We have a separate day surgery unit with 4 theatres, and that's got its own little block room. But,
oh, wow.
Yeah, so on a given day, we might process anywhere from 15 to 20 patients coming through with having blocks.
That's fantastic.
Yeah.
Do you ever get fellows from Australia coming to your hospital wanting to do regional fellowships?
Oh, yes. And I've been saying to people here, and this is not just because I'm in Australia, but I'm always very happy when I get an Australian applicant or a New Zealand applicant.
Oh, right.
Because
well, that's great.
In general, they perform extremely well.
Oh, that's very lovely to hear. But there you go. That's really great for people if they're interested in learning or doing a regional fellowship. We can help maybe tee you guys up.
Oh, yeah. Yeah, just write to me.
Perfect. Now, I noticed that you also have a YouTube channel. You've made over 100 videos helping to guide people through their use of ultrasound, how to do blocks. That's fantastic. That's a great resource. Well done. When did that start?
I had been teaching it ever since I came on staff at the West End, which was in 2008. And around about 2010-11, I took over as the Regional Anesthesia Fellowship Director. So as part of that, I was doing lots of introductory lectures to the incoming fellows on the fundamental techniques. And it sort of got to a point where I was like, there must be a better way, rather than me trying to schedule and find time to have these lectures and some of them can't make it. And then I also realized that there was benefit in people being able to revisit the material because,
correct,
as we all know, you don't really take everything in the first time around you hear it. And I thought, well, how can I give them something to keep going back to? And I have to credit one of my former fellows, Herman Sembi, brilliant chap who came from the UK, and he was already into video creation. And it's thanks to him that he sort of showed me that, you can make these videos, and it's quite easy, and just put them up on YouTube. And so it was almost accidental. Yeah. But driven by this desire to create a resource for my fellows.
Yeah, wow.
And then it just kind of snowballed from there.
Wow. And you're still creating content regularly?
I do. I wish I had more time. I have a
Don't we all?
I have a queue of things that I should do.
Every content producer says that, I think.
Yeah. I mean, I would say that what I'm trying to do now is create content that expresses the little nuances. There's a lot of very good videos out there already on blogs and the basics of anatomy and things. But what I hope to do with mine is I'm a rather detail-oriented person. Persnickety. It's one of my favorite words.
What does that mean?
Persnickety?
Yeah. What's
very
it mean?
sort of detail-oriented.
I see.
Not necessarily entirely complimentary. It's like overly fussy.
Okay, like a little bit nitpicky.
Yeah.
Okay.
But I do believe very much that, distinction between sort of competence and sort of expertise or mastery does lie in the details.
Yeah, true.
And after a while, if you pay attention to the details, they just become habits. So I try to emphasize some of those little things, the tips and tricks.
Yeah.
Because it's very hard, I think, to have that communicated in other formats, right?
I agree.
Like textbooks or journal articles.
Exactly.
Because you don't really want people putting out anecdotes.
Yeah.
But at the same time, I think there's a lot of accumulated wisdom.
Yes.
We all know the experience.
Exactly. I tend to tweak it a bit this way and that way. And it's like, I wish someone would write them down and put them together in a book, but it's not a textbook. Yeah, exactly. So speaking of these, what are some of your top tips for people who want to improve their regional anaesthesia skills or maintain them? What are you commonly saying to people?
I would say the most basic thing about regional anesthesia, it is applied anatomy. That's also what makes it so interesting. So really understanding the anatomy of the block that you're about to do, I think is key. And also, as we often say, it's very easy to get sucked into the technical needling bit, but you've also got to make sure that you're doing this for the right reasons. That it's actually going to help the patient, that it fits into the overall preoperative plan. Increasingly, I find myself making sure I really understand what the surgery involves, what the patient's pathology is, and what their expectations are. And then the blocks fit into that.
Yeah, that's a good tip about just taking that broader picture, stopping and just taking that moment. Yeah.
But then when it comes to doing the blocks itself, as I said, the anatomy, understanding that it's a process, give yourself enough time because you never want to rush, because that's a certain way to set yourself up for either failure or causing harm. So you want to create an environment because, we often get the opposition from surgeons.
Exactly. Yes.
No regional. You're just going to slow me down. So that is a perennial challenge, is structuring your environment that you can find space, both physical as well as temporal. To be able to do the block.
That's a really important tip. It's about having the system to get the patient in early enough, having enough time and space to do the block. Right?
And I would say to start small, find a willing surgical ally who will tolerate you. And then, once you start producing great results for them, all the others will want to join in.
That's true. Good tips. Where do you think we are heading with regional anaesthesia? What are some of the things on the horizon?
There's been a lot of attempts to tie regional anaesthesia to its impact on longer term outcomes. I think we're realizing that some of those haven't come to fruition. Like, does it reduce cancer recurrence? Does it change morbidity, mortality? I think the most notable example, which continues to be debated to this day, were the hip fracture trials, spinal versus general.
Exactly.
I'm not going to go there with the one caveat saying, just remember all those patients were, the eligible patients could have received either. And there are going to be some situations where one, particularly spinal, is probably the better choice. But be that as it may, I think regional anesthesia isn't necessarily going to change things 6 months, 1 year down the road. But at the same time, I think there is merit in what it does for the immediate recovery and enhancing recovery. And I think patients appreciate that, giving them that smoother ride and better experience. Even though, 6 weeks later at the surgeon's office, they don't remember it. I think in the moment, we're making a difference. And also related to that especially with the emphasis now on same day discharges. And I think COVID really brought that home.
Yes, exactly.
Regional anesthesia, I think, has a real role in making sure patients can get out of the hospital the same day in a good condition, in a good state. So I think that is going to keep regional anesthesia alive and going.
Cool. Look, it's been wonderful chatting with you. Is there anything else that you want to say before we wrap up, either about regional anesthesia, medicine in general?
I think I want to say to especially the younger members of our profession out there, remember that it is a patient in front of you, that a lot of times is when you're trying to get to grips with the enormity of all that knowledge that's being thrown your way, you just like want to operate by rote recipes.
Yeah.
But as you go along, I think, and this is, I always say, this is a privilege of anesthesia. So you're only ever looking after one patient at one time.
Such a privilege.
And it's a tragedy if you don't take the time to tailor care to that patient and their specific needs. So it's something I do a lot. So I'd encourage everybody to treat the person right there in front of them at the moment as an individual and say, how can I make your care the best possible? Not just a cookie cutter thing.
That is a wonderful take-home message. Thank you very much for that. And thank you again very much for your time, not just here at the podcast booth, but coming to Darwin all the way from Toronto. I know it's a long way to come.
Well, I thank the Society for having me here. It's been a blast. I always come away with so many things that I've learned, and also people that I've met, wonderful people.
Thank you. Thanks, Jin. Well, I hope you enjoyed that conversation as much as I did. As I said before in previous episodes, these ones I recorded as videos, so you can catch up with them on YouTube if you want the full AV experience. And if you want to catch more of what Professor Chin has to say, then definitely check out the on-demand content, which is available only until the 6th of January. Should be available to everyone who's already registered for the conference. You should have received that email link already. If you weren't able to register for the conference, then don't worry, it's not too late. You can do so to get access to the on-demand content by visiting the ASANSC website, which is asansc.com.au, and that stands for Australian Society of Anaesthetists National Scientific Congress. And finally, I really do think that Professor Chin was serious when he said that he's always happy to have Australian and New Zealand fellows coming to do a fellowship year with him in his department. So if you ever want an introduction, then please do reach out to us. The best way you can reach me is on email, podcast@asa.org.au. All right, until the next episode, I hope you are catching up with some of that on-demand content. And of course, I hope you are staying safe and well out there.